What if I told you that just the simple act of pulling a needle out of your skin creates this microscopic vacuum, like a tiny, invisible physical force that can literally suck a life-altering virus against the flow of an injection straight into a syringe?
I mean, it completely shatters the illusion we have about clean medical procedures.
Right.
Yeah, because we tend to think that, if a provider only pushes down on a plunger, the medicine only goes one way.
Yeah, one-way street.
Exactly.
Yeah.
And therefore, the equipment must remain sterile. But the physics of the human body tell a very, very different story.
So today we are basically dismantling that illusion. We're doing a deep dive into a massive stack of sources to look at the invisible world of infection control.
Specifically in the aesthetic medicine field, which is, booming right now.
Yeah. Oh, highly lucrative, yeah. And we have official CDC guidelines on injection safety, the Northern Ireland Infection Control Manual, which is super detailed, and some truly eye-opening dermatology case studies on severe bacterial infections. Plus, we're looking at highly specific product instructions for cutting-edge aesthetic treatments.
It's a lot of material.
It is. But our mission here is to decode what's known as the chain of infection. We are going to uncover why seemingly harmless practices like sharing a single syringe of filler with a friend actually involve these microscopic dangers most people never even consider.
Which is so important for patients to understand.
Exactly. Most importantly, we want to equip you, the listener, with the knowledge of what safe medical protocols actually look like. Okay, let's unpack this. Before we can even begin to understand how cosmetic injections go wrong, we need to look at how infections travel in the first place, right?
Right.
I know there's like a traditional six-link model for this.
Yeah, the chain of infection. In epidemiology, it basically dictates how a disease moves and survives in the world. So, to give you the ultra-condensed version, you have a pathogen, like a bacteria or virus, which leaves its reservoir.
Like a contaminated countertop.
Sure, or a person.
Yeah.
It leaves through a portal of exit. Then it needs a means of transmission to travel.
Got it.
And finally, it enters a portal of entry, like a needle puncture, for instance, and infects a susceptible host. That's the entire life cycle right there.
See, I always assumed the hardest part of fighting an infection was dealing with the pathogen itself, like killing the bacteria or the virus. But the sources suggest the entire game of infection control is actually won or lost on just one of those links.
Yeah, the means of transmission. It is by far the absolute weakest link in the chain.
Interesting.
And crucially, it is the only link that healthcare providers have complete control over. I mean, we can't always destroy the bacteria in the environment, right?
Right.
And we can't always cure the host's immune system on the spot.
Right.
But we can completely stop the pathogen from catching a ride into the body.
It's kind of like a prison break. If a prisoner has a highly complex, six-step plan to escape, you don't need to foil all six steps. You just need to lock down one specific door.
That's a great way to look at it.
If you secure the means of transmission, the entire escape fails. But let me push back on this a bit because it sounds a little too neat.
Okay, go ahead.
If stopping infections is as simple as breaking one link like just washing your hands or throwing on a pair of sterile gloves, why are healthcare-associated infections still such a massive problem globally?
Well, because the theory is simple, but the execution in a fast-paced clinical environment is staggeringly complex.
Just too many moving parts.
Exactly. Hand washing is foundational, obviously, but it is not enough on its own, especially when you're dealing with procedures that break the skin barrier. This is where we have to look at a framework called aseptic non-touch technique, or ANTT.
Ah, right. I saw ANTT mentioned all over the Northern Ireland Infection Control Manual. What does that actually look like practically when someone is preparing an injection?
It requires the practitioner to mentally map out two very specific categories before they even touch a patient: key parts and key sites.
Key parts and key sites. Okay.
Right. Key parts are the sterile pieces of equipment. This includes the tip of the syringe, the needle hub, the shaft of the needle itself.
And key sites.
Key sites are the patient's vulnerable areas, which, in aesthetic medicine is the exact millimeter of skin where a needle is going to puncture. The absolute rule of ANAT is that a key part must only ever come into contact with another key part, or a key site.
So it's not just like, are my hands clean? It's this hyper-awareness of geometry.
Yes, perfect word for it.
Like ensuring that absolutely nothing non-sterile, not a glove, not a countertop, not a stray piece of gauze ever brushes against that needle.
Because the margins for error are microscopic. Pathogens vary wildly in their infectivity. We walk around every day covered in our own normal flora, right?
Like the good bacteria.
Yeah, bacteria that naturally live on our skin and actually serve a protective function. But if a practitioner's sloppy technique pushes that normal, harmless surface bacteria down into a deep dermal layer through a needle puncture, the game changes entirely. Yeah,
Oh,
that exact same bacteria becomes an opportunistic pathogen simply because it was introduced to a part of the body that cannot tolerate it.
which brings us to the physics of the syringe itself, because this is where the means of transmission seems to get compromised the most in these cases. The golden rule in the CDC guidelines is one needle, one syringe, only one time.
A standard that is unfortunately sometimes ignored, and it's often due to a profound misunderstanding of physics and microbiology.
Really? How so?
Well, there's this pervasive myth that if you use a syringe on a patient, you can simply pop the needle off, attach a brand new sterile needle to that same syringe, and safely use the remaining medication on a second patient.
I have to admit, intuitively, I can kind of see why people might think that.
Sure, it seems logical on the surface.
Right, because if I'm the provider and I only push the plunger down to inject the medication, I am only applying positive pressure. So if I never pull the plunger back to draw blood, how is it physically possible for the syringe barrel itself to become contaminated?
Okay, let's look at the physical reality of what happens when a needle exits human tissue.
Let's do it.
When a provider removes a needle from a patient's skin, a sudden change in pressure occurs. Tissue is elastic, right? It has its own internal pressure.
Okay, yeah.
So as the needle pulls away, the fluid dynamics shift in just a fraction of a second.
Yeah.
Even if the provider only pushed the plunger, the sheer act of withdrawal creates a microscopic vacuum effect, a split second of negative pressure.
Wait, really? So that tiny vacuum actually sucks a microscopic amount of blood and tissue fluid backwards,
Yeah.
like against the flow of the injection, up through the needle and directly into the hub of the syringe.
The physics guarantee it.
Bro.
And because the interior barrel of the syringe now retains that microscopic backflow, the syringe itself is highly infectious.
Oh my God.
So changing the needle does absolutely nothing to protect the next person. If you take that contaminated syringe, put a new needle on it, and dip it into a multi-dose vial of medication to draw out more product, you have just contaminated the entire vial.
So every subsequent patient who receives medication from that vial is now exposed.
Exactly. To a bloodborne pathogen.
It's like sharing a milkshake.
Okay, I like this.
If two people are sharing a milkshake and one person uses a straw, you can't just swap out the straw, hand the cup to the second person, and pretend it's completely sanitary.
Right, because the backwash didn't just stay in the straw.
Exactly. It went into the milkshake itself. The syringe hub is the milkshake.
That is a very accurate analogy. But, instead of a cold virus, we are talking about life-altering pathogens here. The CDC reports detail catastrophic outbreaks linked to this exact breach in protocol.
It's terrifying.
We are talking about massive hepatitis B and hepatitis C outbreaks because providers double-dipped into IV bags, or they shared insulin pens between diabetic patients, or reused syringes to draw propofol for anesthesia.
And the survival times of these viruses are staggering, too. I mean, the sources note that hepatitis C can survive in dried, microscopic blood on environmental surfaces for up to 16 hours.
Yep.
And hepatitis B can survive for up to a week.
Which is wild.
And millions of viral particles can exist in a droplet so small you can't even see it.
Which is exactly why the CDC classifies a syringe as a single-use device without exception.
Okay, so this applies directly to a trend we see constantly in aesthetic medicine right now. Friends splitting a pre-filled syringe of dermal filler.
Oh, yes, the social media trend.
You see it on TikTok all the time. Two people go to a clinic. They only want half a syringe each to save money, so the provider injects one person, changes the needle, and injects the other with the remaining product.
It is incredibly dangerous. Dermal filler syringes do not have one-way valves. There is zero mechanical barrier preventing that microscopic vacuum from pulling blood into the hyaluronic acid gel inside the syringe.
So if you share a syringe of filler, you are intimately sharing blood.
You are. The risk of transmitting HIV, hepatitis B, or hepatitis C is very real.
Okay, so sharing fillers is clearly a massive risk. But what about the really advanced, newer treatments hitting the market? Because, people tend to assume that the newer, more expensive, and more scientifically advanced a treatment is, the safer it inherently must be.
That's a dangerous assumption.
Let's look at polynucleotides, because our sources are packed with data on products like Plynest, Nucleophil, Amila, and Rich's Eyes.
Right. Polynucleotides, often abbreviated as PN or PDRN, they're a fascinating class of biostimulators. Unlike traditional fillers that just take up space and create volume, These are highly purified DNA fragments.
DNA fragments.
Yes, typically derived from the reproductive organs of wild salmon or freshwater trout.
So it's literally fish DNA for your face.
Essentially, yes.
Yeah.
Through these really extensive purification processes, the proteins and potential allergens are stripped away, leaving just pure nucleotide chains. And when injected into the dermis, these DNA fragments signal your skin's fibroblasts to wake up. They stimulate the endogenous production of collagen and elastin.
Wait, hang on. Endogenous production. Just to be clear for the listener, that means the body is producing its own collagen from within rather than having like foreign collagen pumped into it, right?
Right. Endogenous means originating from within an organism. So the polynucleotides act as a signaling mechanism to kickstart your body's natural regenerative processes. It promotes tissue repair, improves hydration.
Sounds amazing.
It is. And the research notes that newer PN products usually have longer nucleotide chains and a higher molecular weight than the older PDRN products, which provides a stronger structural scaffold for the skin.
But the packaging is the critical element here for infection control, right? Whether it's plainest or nucleophile, the sources are explicit that these products are manufactured and sold as sterile, pre-filled syringes.
Yes.
They are strictly Class 3 medical devices meant for single patient, single use only.
They are entirely self-contained units. Yet, because these biostimulator treatments require multiple injection points across the face, and they're often administered in, like, med spas rather than clinical surgical settings, the chain of infection is frequently broken during preparation or administration.
And the case studies in the dermatology journals regarding this are incredibly intense.
Oh, they are grim.
We reviewed a report from the Journal of Mycology and Infection about a 60-year-old woman in Korea. She presented with this solitary, deeply indurated, purplish plaque on her face around her mouth.
Right.
It had been there for a month, growing worse, completely unresponsive to standard antibiotics.
And after a biopsy, the bacterial culture yielded Mycobacterium abscessus.
And in another case we looked at, a 53-year-old woman developed multiple firm, painful red nodules on her face 2 months after a filler injection. That one turned out to be Mycobacterium chelonis.
Both of these are classified as non-tuberculous mycobacteria, or NTMs. They are rapidly growing bacteria that are incredibly insidious when introduced to human tissue.
Wait, I need to pause here because the sources say these NTMs are ubiquitous in the environment. Like, they live in dust, in tap water, in soil. You're telling me these soil bacteria survive clinical-grade disinfectants?
They absolutely can.
That doesn't make sense to me. If a clinic wipes down their countertops with bleach or a medical-grade cleaner, how is the bacteria surviving to cause these infections?
Well, it comes down to their biological structure and how they behave in environments like tap water. Mycobacteria have a unique, highly lipid-rich cell wall.
Like fatty.
Yeah, exactly. And that makes them naturally resistant to many common chemical disinfectants that would easily destroy standard bacteria. And, in places like clinic sinks or water pipes, they can form biofilms. Yes, protective layers that basically shield the bacteria from cleaning agents. So if a clinic washes reusable instruments in tap water, or if a provider sets a sterile needle down on a surface that was wiped with a weak disinfectant, or even if they accidentally touched the syringe tip to a non-sterile glove, these resilient bacteria catch a ride.
And once they are pushed deep into the dermal tissue by a needle, they completely bypass all the skin's natural defenses.
Exactly.
But the incubation period is wild to me. The sources say it often takes 3 weeks just to show up, and nearly 10 weeks to actually get a correct diagnosis. Why on earth does it take so long to figure out what's wrong?
Because the clinical course is indolent, meaning it develops very slowly. The nodules take weeks to form.
Okay.
By the time the patient develops these hard inflammatory bumps, they might not even connect it to an injection they had 2 months prior.
Oh, that makes sense.
Right, and this leads to a dangerous cascade of misdiagnosis.
Yeah.
Because the lesions look like localized inflammation, doctors frequently mistake them for a foreign body granuloma.
Let's define that really quick. A foreign body granuloma is basically the immune system walling off something it doesn't recognize, like a piece of filler, right?
Yes, it's an immune reaction, not an infection. And the standard medical treatment for a granuloma or a severe allergic reaction is often to prescribe corticosteroids to calm the immune system down.
Oh, no. But if it's actually a hidden bacterial infection, prescribing steroids suppresses the immune system, leaving the bacteria completely unchecked to multiply.
Which makes the infection significantly worse. Eradicating NTMs like Mycobacterium abscessus often requires months of aggressive combination antibiotic therapy.
Months?
Yes. guided by highly specific molecular susceptibility testing. And sometimes it even requires surgical excision of the infected
To
tissue.
literally cut it out.
Yes.
Okay, so considering everything we've just discussed, the microscopic vacuums, the resilient soil bacteria hiding in biofilms, the risks of sharing pre-filled syringes, what does the right way actually look like?
That's the million-dollar question.
Because I really want to focus on this. How do specific sterile technique protocols prevent cross-contamination when using multi-dose vials or transferring from these polynucleotide pre-filled syringes?
Okay, so it starts with understanding the difference in packaging. As we established, products like polynucleotides come in single-use pre-filled syringes. But some medications, like certain neurotoxins, come in multi-dose vials that have to be reconstituted with sterile saline.
Now, the multi-dose vials contain antimicrobial preservatives to help inhibit bacterial growth, right? But the sources emphasize that those preservatives offer zero protection against bloodborne viruses.
None whatsoever. So the protocol dictates that multi-dose vials should ideally be dedicated to a single patient.
Okay.
If they absolutely must be used for multiple patients, they must never enter the immediate patient treatment area.
So keep them far away from the chair.
Exactly. They should be kept in a designated, centralized, clean medication preparation area, far away from sinks where water might splash and bring those NTMs we talked about.
Yeah.
And every single time that vial is accessed, it must be with a brand new sterile needle and a brand new sterile syringe.
The clean versus dirty workspace demarcation is vital then.
Totally vital. You cannot prep injectable medications in the same workspace where used needles are dismantled.
Okay, but let's look at the pre-filled syringes. Because often a provider wants to transfer a product, like a polynucleotide or a filler, from its original larger pre-filled syringe into a much smaller syringe, like a tiny BD syringe, for precise facial work, right?
Right, for better control.
So how is that done without breaking the chain of infection?
This is where aseptic non-touch technique becomes a literal tightrope walk.
Okay.
We reviewed protocols, like the one outlined by Dr. Tim Pierce, regarding transferring product into a tiny BD syringe. First, the provider must wear sterile gloves.
Step one.
Then, they have to carefully remove the plunger from the receiving syringe. Crucially, they cannot let that plunger touch anything. Not the tray, not the outside barrel of the syringe, nothing.
Because if the plunger touches the counter and then you push it back into the barrel, you just pushed counterbacteria directly into the medication.
Exactly. You've contaminated the entire thing.
Okay.
So, after removing the plunger safely, the provider carefully introduces the needle of the original pre-filled syringe just inside the barrel of the empty receiving syringe to inject the product.
And they have to do this while managing fluid dynamics too, because the sources note how dangerous it is to create air bubbles during this transfer.
Oh yeah, that's a huge issue. If you pump the product too quickly and create a suspension of tiny bubbles in the gel, you end up injecting air into the patient's tissue instead of the product.
Which compromises the entire treatment.
Right, so every movement, from opening the sealed blister pack to the exact angle of the product transfer, must be calculated. You can touch non-key parts with confidence, but you never touch the key parts.
Which brings this entirely back to you, the listener.
Yeah.
Sitting in the treatment chair, you have every right to advocate for your own safety based on these exact protocols.
You absolutely do.
You can ensure they don't touch their phone or adjust their hair after their gloves go on. You should expect to see sealed, sterile blister packs opened right in front of you.
And if they offer to save the rest of your syringe for next time, you run.
Run! Because knowledge fundamentally shifts the power dynamic here. By understanding the rigorous, uncompromising standards required to keep these procedures safe, you can recognize immediately when a clinical environment is cutting corners.
It's all about being an informed patient.
We've covered a lot of ground today. We traced the actual mechanisms of the chain of infection, focusing on how easily the means of transmission is compromised.
Right.
We broke down the invisible physics of negative pressure that turns a reused syringe into a potential biohazard. And we looked at the specific sterile protocols required to keep advanced biostimulators, like polynucleotides, from becoming vehicles for incredibly resilient environmental bacteria.
It all underscores a central truth, really. Aesthetic procedures are serious medical interventions.
They aren't just facials.
Exactly. The moment a needle breaks the skin, you are bypassing the body's primary defense system. The only thing standing between a successful cosmetic outcome and a complex medical complication is the meticulous, unbroken technique of the provider.
Which leaves us with a final thought to mull over. We explored how a microscopic fraction of a second of negative pressure can pull a virus into a syringe hub, completely against the flow of an injection.
Yeah.
It's a physical force we cannot even see, operating in the blink of an eye with massive consequences. It really makes you wonder, what other hidden, invisible physical forces in our everyday medical or personal care tools are we completely taking for granted? Until next time, keep digging deeper.